Hi everyone, I'm Mike Woodall. I lead the impact evaluation team at the strategy unit, and we've been commissioned by NHS England to develop a guide for analysts to better use ethnicity data. So, to identify some of the kind of issues with the ethnicity data that's available, identify elements where people can improve that data or can improve the use of that, and then to add in some best practice examples. So realistically, I'm here today to ask for your help. So we can't do it all on our own. We don't have a kind of full picture of how ethnicity data is used in every area and how it can be improved. So what we want to do is build a guide that's useful and is the most useful guide for analysts. So we're not at the moment we're not talking about the kind of data collection end of this. So we're talking about dealing with the issues that are currently in the data collection. Um, and then that would be picked up separately. So this builds on some work that we did for NHS England, which looked at kind of the use of ethnicity data and to develop a plan to improve it from start to finish. So from data collection within organisations all the way through to analysing and realising the impact of using that data. So I'm going to give a broad overview of what we did and some of our findings in terms of data quality. It focuses very much on NHS data sets, but we are looking to include more information on using other data sets, so care data sets within care, ONS data sets, and potentially other areas that we could look at. So let's see if I can make my slides move. So what I'm going to do is talk you through some of the background to what this project is and why we're doing it, the findings from our previous work, so the elements that we looked at in terms of data quality and ethnicity recording across health data sets, our proposed approach, and that's what I really want some feedback into. So are we focusing on the right things? Do we need to add in other elements? And are the things that you've done locally that you could feed in, are the best practice examples that you'd be willing to share and that we can build into this guidance? So that's what we're going to talk about. So in terms of this, I don't think we really need to kind of reiterate this. Well, I know we do need to reiterate this a lot, but everybody knows that research has shown that ethnic minority people report poorer healthcare experiences and outcomes compared to white British people. And this this is partly due to lack of accessible information about the services, language barrier, and a mistrust of healthcare and statutory services. And good quality data, so data that's complete, is accurate, is up to date, and consistently recorded across systems. So the same person has the same ethnic group in all the data systems, is essential for both effective planning, looking at quality improvement, so improving services, monitoring equity of services, looking at background inequalities and all sorts of areas. So actually, ethnicity quality within healthcare remains variable. So there are problems within it. It's not just in terms of kind of missing data. There's often a use of codes that are not helpful. So people coded as not known, significant numbers in systems and other areas. So there's no identification of the true ethnic group. And there's a real I don't think there's any real understanding about whether the missing data is representative or not. So, where we're not collecting, where we're putting people as not known, is that broadly representative of the background population that they use that services, or is there some bias in that data? And that data quality and the use of data does have consequences. It has consequences for patients, access to health and care services, how we plan and deliver services, and also in terms of research and innovation. So ensuring that that's inclusive and the data identifies the areas that we need to look at in different ethnic groups and the requirements and needs of those groups. So, so the previous work looked at developing an improvement plan. As I said, this goes from start to finish, but we're looking more at the finish area. So we looked at a document review. So we reviewed a whole set of documents. We had interviews with 21 people to understand how the kind of impact and use of ethnicity data and the impact of kind of varying data quality. We developed some case studies, so we looked at some improvement case studies. We looked at the data set review, which is what I'm going to talk about now. So we looked at routine data sets around acute, community and mental health services and did some comparisons across them as well as within the services. It was aligned with the wider work around improving ethnicity data quality, and we've gathered feedback on it. So this is available. It's on our website if anybody wants to see the improvement plan and the blog that Abby wrote to go with it. That's all available, so you can go and have a look at that. So in terms of the data quality, we did look at. So I think we used 24-25 data because that was the full year that we could see at the time. And what we looked at is not just those that were null values in the data set, but those that were coded as not known or similar coding. So we can look at the proportion of data that was missing. So this looks at, so the coding goes from 9, which is not known, which is the orange bar, null, which is blue, and Z, which is not stated. So we can see that actually the amount of codes that are not known or not stated actually are higher than the ones that are missing. So people are using these codes in different data sets. So there are data quality that processes that look at whether there's code included, but a lot of times they are looking at not known and not stated codes, which then are not useful in terms of the analytics that we want to do with this data. So yeah, and in particular, CSDS, which is the sort of the data set that was developed soon, yeah, closer to where we are today. So it's the last one to be developed. There are bigger data quality issues within that than there are across the other data sets. So yeah, so that's what we looked at. And then we looked at kind of by provider. So we looked at different providers and we looked at the median, and then we looked at a level where they had high missing data. So we looked across each provider that was in the data system, and in inpatient data, the median was high in terms of valid ethnicity recording. So 87% had a valid record, but there were 20 providers that had much lower quality and sort of low levels. So the kind of average is being brought up by the others. ETDS, again, high levels of ethnicity recording, but much fewer providers with high missing data. Outpatients, it goes down, and there's a high level of providers that have high levels of missing data. And again, in community and mental health, it goes down, and there's a fewer level of missing data. So we know that there's issues in all the data sets, and we know that specific data sets have bigger issues than others. We then looked at this over time, and it seems that the actual data gets worse over time for most data sets. So For the admitted patient care, emergency care, and outpatient data sets, so the acute data sets, the amount of missing ethnicity data or missing or invalid ethnicity data has increased over time. So for the last 5-6 years, it's actually getting worse. For CSDS, it's kind of constant, but it is worse than everything of the other data sets. Whereas the mental health data set actually was getting worse year on year, but it's starting to move back. So the mental health services data set is actually starting to improve in terms of ethnicity recording. We did look at the consistency of NHS data with census data. I need to really caveat this because obviously within ethnic groups there are confounding issues such as the impact of ethnicity on service access. So access rates within certain ethnic groups are lower, and therefore you may not expect their ethnicity to broadly the ethnicity of people using services may not match the census. But there are some areas where we think there's higher or lower levels of ethnic groups than there are in the census, and particularly those that are called that start with any other. So any other ethnic group, any other Black background, any other Asian background, and any other mixed background, there are higher rates than are in the census. So there may be something about the coding of people to those groups within organisations that don't look at the kind of other categories. And then there's lower recording in different groups, so Irish, mixed, white and Asian or Asian British, Indian. So there are some areas where they're lower than the overall group, but again, that may be influenced by confounding factors. So this is more a kind of observational piece for people to use in terms of what they might want to look at in terms of improving data quality and areas that they might look at. But I think the most interesting kind of element is that use of any other in the coding, and whether that really is accurate or whether people do want to look at that in terms of whether people are being over recorded in that group. And then we looked at the consistency of ethnicity recording across data sets. So this tracks any individual person. So NHS, well, pseudonymized NHS number. We looked at a person across each of the data sets that they were in. We then only used the ones that were in more than one data set. And we looked at whether their ethnicity was the same in every single data set. So 44% had the same recorded ethnic group. So we removed all the invalid and missing codes. So we're only looking at valid codes. So 44% had the same ethnic code in each of those groups. 25% had a different one. So there was no consistency whatsoever. And 31% had a mix. So they had the same ethnic group in more than one data set, but it wasn't consistent across all. So they may have had inpatients and outpatients were the same, but when you looked at the same person in the community data set, their ethnic group was different. So it's a real issue in terms of consistency of recording across different systems. And this influences, obviously, this influences the data collection and recording of data, but it also has an influence over our analysis. And it is things that we need to think about when we are analysing data and how we describe this as limitations and how we might mitigate for this in any of our analysis. So yeah, so the guide provides 5 high-level domains for action. So the first one is requesting. So people working in health services who are talking to patients and carers are requesting their ethnic data and to ensure that people are more confident and skilled in that area. Providing so that the public is aware of the value of this data. So we're providing information that helps them to be more willing to provide that information. So it's about improving their care and improving other areas. So we need to be clear why we're collecting that data and how it benefits patients. And then there's a recording of that data. So it's making sure that people accurately record it in data systems. So it's recorded there. And then the bits that were more kind of closer to what the guide's looking at is the processing of ethnicity data. So ensuring it's consistently processed through sort of data sharing and analysis, and the use of that. So there's no point collecting any data unless we're going to use it, and there's no point in using it unless we're going to use it to improve services and improve services for these groups. So we need to really ensure that what we do in terms of analytics is the right quality. It identifies the limitations of this data, but it provides useful insights to improve services. So that's kind of what the guide is focused on. So this is really brief. These are our initial thoughts on how we would structure the report, and I've got some questions that come out of this. So we'd provide an introduction in the report that describes the importance of analysing this data, describes the purpose, describes the background, includes links back to the plan that we've already done, so the improvement plan. So it would focus on that. We'd have a section on data sets and coding. So this would describe how ethnicity is coded in different data sets. So we know that some data sets are still using the 2011 census ethnicity categories, and some have moved on to the 2021 categories. So there's some issues around that, or some elements around that. We'll look at any overlaps and any differences in that coding. So we can look at differences in how data is coded. Is it coded differently in social care data, primary care data, other data sets? And describe the impact that can have on analysis. So making sure that we're providing useful insight for people in terms of the impact of different coding methods, how they might be mitigated, and some of the other elements. We want to identify known issues, so things that people are coming against time and time again. So we want to describe those issues in ethnicity reporting and recording, and we want to provide options for mitigating those things. So can you use things like imputation to fill in missing data? Do you need to exclude them? Are there other methods that we can use? Can we link data and use data from other data sets, from data sets with higher levels of data quality to fill in any gaps? But those elements. So one of the things we will put out after this is a request for people, if they're able, to share some of the issues that they've had and some of the ways that they've got around those issues. That'll be really helpful. We've then got a section looking at data quality, so it will describe the common data quality issues and the pros and cons of the different options for managing that data quality and missing data issues. So it links back to the known issues, but it's specifically around data quality. And then finally, we want a set of good practice examples. So we want summaries of analyses that different people have done across different areas. So within provider organisations, public health, commissioning organisations, social care. So across the range of different ways in which you can use this data. So in terms of both providers, but the type of analytics that people are using this for. So whether using it within evaluations, which is what I specialize in, or if they're using it in modeling, descriptive analyses, PHM, other areas. We want to try and identify some of those and describe what's most important is the purpose of that analysis. So why was it done? How does it help in terms of improving services? The methods that we use, so not just the analytical methods, but particularly the methods around managing ethnicity data and data quality, a brief description of the results, and just as importantly, any limitations that are shown in that data. And we think these examples will provide a basis for other analysts to pick up the work, potentially to contact each other, to talk through what's been done, although we will talk to people before publishing any contact details, so we'll make sure that people are comfortable with that before we do that. But the idea is that this is the most practical guide that we can provide, and it isn't focused on mine and my team's sort of narrow view of using this data. It's actually as wide as we can get it, and we're getting your intelligence and everything from other groups like this. So we want as much input from people as we can. We may not publish every example, but we can reference them within the guide. Ideally, good practice examples would be publicly available, but we are aware that that may not be possible in some areas. So as long as we can describe what's happened and provide the results at a level that are comfortable for the organisation, we're happy to add in examples where the data isn't available. So yeah, so that's the majority of my talking at you. So what we really want from this discussion is, does the guide that we've described, I've described, does that sound useful to analysts? So I guess in the first instance, should we even be doing this? Is it a useful thing? Will analysts use it if it's available? Have we missed anything from the report structure? So is there anything that you think is really important about using ethnicity data or within analytics that we need to make sure is covered in what we do? And then finally, and we don't necessarily need to pick all this up today, but if you have any examples that we could use as good practice, it'd be really good to get examples of those and be able to kind of link in with people to follow up. So that's the discussion that we'd like to go through now. Before we start, are there any questions about what I've discussed or anything that anybody wants to go through?
So we've got a hand up, Kate. Hiya, that's really useful. And I've seen the report online previously. The elephant in the room for me, and it probably needs to be addressed in your outputs, is the whole, we're asking this data to be captured multiple times and almost inevitably it's going to be different, is that I don't think, I think I'm right, the last time I looked into this depth, I don't think ethnicity is available via PDS and sort of the central link. And because thinking about it logically, why wouldn't we capture it once and then share everywhere? And I'm guessing there are barriers that don't allow that to happen. And I think it'd be quite useful to address that as part of your outputs, because well, there'll be lots of logical thinkers on here that as soon as you see that disparity in the data that's captured, you think, well, we just need to capture it once and share, because we all know that that's what happened. If in theory you're capturing the same thing in multiple places, it will not all be the same usually. I guess you've had those conversations, and it just might be useful to have that context as part of your outputs, I think.
Yeah, we very much need to reflect on that and make sure that that's part of the recommendations. yeah, it's definitely a really important message to provide back, because it is very odd that we record it all in different systems. Yeah, and yeah, I think the findings from the initial piece of work were that some of it is how somebody feels on the, somebody might provide a different ethnic group because that's how they are on the day. So Abby can probably provide a little bit more input into that. But yeah, we will make sure that that's covered. Abby, do you want to
Yeah, I can do.
respond?
Thank you. Yes, that elephant in the room is very much there. It is known. We picked it up as part of our interviews. We did interview kind of the teams like ONS who are also kind of tackling with the same issue. So that we built it in as a recommendation to NHS England. And there are mechanisms to be able to do just that, to input it only once. Where that entry is, that's the difficulty. So, for example, some of you might be aware that we do enter everybody's ethnicity once at birth. If you're born in this country, and that 6 months later, that data is deleted for data protection issues. So there are mechanisms that already exist, but we have the barriers are around data governance at this moment in time, which gets in the way. So there is work for the NHS and across other public agencies for national data sets to be able to kind of go across it, but it's harder than we all think. I think the technical ability is there. It's just not the data governance around that, is it?
Thanks, Abby. We've got a few people with their hands up, so I think it's probably sensible to work through those before we have a look on Slido. And I think some of the people's questions may have been repeated on Slido, so it's an opportunity to talk through them. If you're not about to talk, if you could maybe pop yourself on mute, that'd be great. Just check you've hit your mute button, but not you, Jonathan, because you're next up. Do you have a comment or a question?
Bit of both, perhaps. Yeah, thanks, Mike. Really, really interesting, really valid and important work. So I work in Newham, which is the most diverse borough in the country. And Newham Council has really comparatively really high levels of trust with the community. I thought just the comment be really interesting to look at the correlation between the quality of recording and levels of diversity and levels of trust, which I think are measured across the country, would be quite an interesting piece of work. And just on the consistency bit of work, so did you look at take individual level records and find those people in different data sets to make that comparison? I was just sort of interested how you did that.
Yeah, so we use the data in UDAL to look across all those data sets. So each person has a pseudonymized NHS number in each data set. So we removed any duplicate people, because even in the same data set, there might be slightly duplicate people. And then we have essentially went across all data sets. So we said, does it equal this in this? Does it equal this in this?
Yeah.
And every combination of that. And only 44% of those people who are in more than one data set are consistently recording in every single one of those data sets. We removed all the null values and things like that. So it's not about them being recorded as null. It's about them being recorded differently. Yeah.
And the one other thing is, like, a key data set of really important in COVID was the mortality data set, which doesn't include any ethnicity data, which is absolutely crazy.
Yeah. Great. So it's really important that we capture that element about trust, and perhaps we could talk to you, Jonathan, about the work that's been done in Newham and look at whether that could be part of our our good practice examples, because it'd be really interesting to understand how that was done, so that can be made available to other people.
Yeah, I'd be happy to. Yeah.
Great, thank you.
Thanks, Jonathan. That's really helpful. We'll be in touch after today. Thank you, Simon.
Hi, yeah. So yeah, lots of
Hiya.
people covered on the data quality and recording at once stuff, which is obviously really, really good. I guess once we have got some really, really good ethnicity data in, I guess the question is, how do we actually analyze it to get something meaningful? So, for instance, I live down here in sunny Devon, and the ethnic makeup of Devon is completely different to inner city Birmingham, for instance. So how do we develop and report on our ethnicity data so we've got a good counterfactual to show whether our ethnicity breakdown of this thing is actually meaningful and does mean anything? Because that's a really massive challenge. And simply reporting, here is the descriptive analysis of here's my ethnic group, great, so what is that? Is that different? Is that meaningful? So I guess there is a bit of how do we actually pull out that meaning from our ethnic breakdown or whatever that we pull out.
Yeah, thanks for
that's
that.
covered in there.
Well, I'm hoping that what we want to look at is best practice examples of work that people have done. So I'm hoping some of those analyses that are more, I guess, more interesting and more innovative, hopefully would be captured in that. So we would have a range of different practice examples of different types of analyses, a range of different techniques in which they've managed data quality, how they've described their limitations, but that would give you a basis to develop those analytics later. And if we could develop those types of projects on a much better kind of bed of data, so we've got a much better foundation, then obviously those will improve in the future. So yeah, hopefully the best practice examples will help that, but yeah, we need to source them more. But there may still be gaps of things that people think are really interesting but just never tried. And perhaps if we can capture some of that within this, that'll be really, really helpful.
Yeah, no, it's a really challenging problem for sure. And yeah, I'll see if I can to get some examples for you.
Great, thanks,
so
Simon.
that's another offer of examples, Mike. We're doing well. Let's see if we can get some more. Okay, so next let's cover off one or two more of the people who've got their hands up, and then we can turn to Slido. We've left plenty of time for discussion, which was the intention today. So Paul, do you have a comment or a question for Mike?
A few comments, I suppose. I've spoke to PDS recently, and I was told that they are working on trying to incorporate this, and they were looking at a pilot with an ambulance trust. I can't remember which one it was though. Second thing is that we tried to do some work with primary care to look at sharing and populating our data set because our data collection is really poor. But we did run into IG issues, and which we never got resolved in the end. And the third thing was I wrote a paper on ethnicity data collection a couple of years ago, which I can share with you. If you could let me know your email address, please.
Yeah. Yeah, no, I'll put my email address in the chat. Be really interesting to see that. Yeah, primary care data is a really interesting one because there's no national flow. There is work within things like Open Safely to use that. So there may be potential to at least test whether we could improve ethnicity data using primary care. I have looked at it before, and I wouldn't necessarily say that primary care data is going to improve the data quality of ethnicity recording. There's quite a lot of, because it's not a requirement to send it anywhere, there's quite a disparity in terms of how well it's collected. Or there was when I did this, but it's like 10 years ago. So there are some issues with that. And also SNOMED codes have a much wider coverage than the national ethnicity code. So it might be a way of capturing some of those underserved populations. So things like Gypsy, Roma, Traveller communities that don't turn up in any other data sets. It may help with some of those, but we would need to look at that data quality.
Okay, thanks, Paul. I'll be interested to see your paper as well, so you'll have to send through a link to that as well. Thank you. So we have we've got a couple more people who had their hands up, so I'm really keen to get people in the room. So Beverly, would you like to ask a question for Mike?
Yeah, it's kind of a question, but it's kind of what I've learned from experience so far.
Sure.
So I work for a CSU, very lucky in that we can get data from census, DIDS, and the System 1 and the primary care data for our ICBs, where the governance has been signed off, etc., etc. And I'm just trying to think, community, mental health, all of those data sets. So what I did at one point, because I was thinking what's the best way to do it, I pulled it all together into a table. And I did find that, just going back to what Mike said, primary care was probably the richest source of information. But obviously very fortunate to be in that position where we can access the GP coded data and the SNOMED codes and such like. But what do people do? And this will happen, I'm guessing, in some data sets more than others, where you have conflicting ethnicity data. So I'd just gone for the latest. I just ranked it, but went by latest. But do other people have this issue? And I suppose is how do they deal with that? Because I could do a set of analysis on something based on all of the data sets that I've brought through and got the latest, and it actually, the results might look very different to someone that's only got access to another data set. And it's like, how can we align that? Well, that's very difficult unless we've all got access to all the data. But it's that contradictory ethnicity, and some of that might be data quality as well. But there are quite a few.
Yeah, so that's one of the
question, comment type.
So I think that's one of the areas that we'd really like to capture in our guide. So maybe we won't go through that today, but we can bring this back once we've been around different areas.
Yeah.
I suspect people will have multiple techniques and will record them as limitations in their analyses. But yeah, there will be multiple ways in which people do it. So hopefully we can capture those, not just the issue that's there, which we know it is, that there is conflicting, but some of the ways that people have mitigated it, and at least a kind of very broad assessment of whether that's been effective. So yeah, so we're hoping, so that would be included. We'll make sure that that's captured, and we can bring that back to another meeting.
Thank you.
Thanks, Beverly. So we have a couple more people with hands up. So I might just turn to before we go to Meg. Might just turn to Slido, Mike. If I just share my screen, there's way too many to go through, but we might just want to pick on one or two. While I'm just sharing my screen, there's and if you're logged in, you'll be able to see the responses anyway. But you're too busy because you're presenting. There's a few questions around. I think one from memory says that surely the GP data, the primary care data, is the source. You know, that's where it's most accurate, and that should be used. But that's not necessarily always the case. I would just share my screen so we can see if I can't find that one. There are ones which are similar as well.
I would say that the primary care service, the primary care system is the ideal place. Not necessarily due to current data quality, because we don't really know what that's like across the country, but it's the most extensive system in terms of ethnicity. So not everybody turns up in the acute, or some people potentially never, and certainly not every year. Same with community mental health and other data sets, whereas primary care holds the records for everybody who's registered with a GP practice. So it's definitely the most comprehensive, and it would be where you would choose to build up your national register from, but the data governance and potentially data quality issues within that, and particularly consistency across practices, it would take a lot of work to use that data set. But yeah, what we might look to do is, what we'll hopefully do is identify some case studies where people have been able to use primary care data, and if we can describe those case studies, that might help with that question.
Okay, so yeah, absolutely. So I think one or two of these were talked to, I think, in the room. I think this is the bottom one, which is about sort of a master patient record. Now, wouldn't that be nice? So a single record, which is kind of the thing sort of that we've been trying to achieve for a long time, I guess, for many reasons. Not just for sort of the accurate coding of ethnicity, but for lots of other reasons. So that would be the ideal. That would be the gold standard. But there seems to have been over the years and continues just so many reasons why it can't be done. But I imagine, however, in some areas this is being achieved in more ways than in other areas. So there might be some good examples of that.
Yeah. So we'll take away everything that comes through here, review it all, and work through how we can build it into our report. And if we have got quicker answers that we can share with the group, we can share that. We'll also put out a kind of request through the group for examples with contact details and everything else like that. So we'll make sure we go through that, and if we can pick up the questions in the room before we finish, that would be really helpful.
Yeah, absolutely. So I'm just having a flick through, and I just want to reassure people that whatever goes in Slido, we do pay special attention to that afterwards as well. And it will, like Mike says, it will get fed into the development of this guide, because it's really important to reflect what you think and the challenges that you've got and the solutions that you're coming up with as well. So let's go back to the room. Meg, you've been very patient. Do you have a question or a comment for Mike?
Hello, thank you. Hi, I'm Meg. I am a Principal Health Analyst at the UK Health Security Agency, and a lot of agreement with what's already been said in the room. So within UKHSA, we are developing a best practice guide for health equity metrics as a whole, of which ethnic group is one of those. And we would like to have access to the GP data, but we don't currently. So what we're doing is developing a composite ethnic group table, and what we're trying to do is have one agreed method across the organisation about how we link data across lots of those different sources that you've mentioned. And at the moment we're following a method developed by DHSE and OHID during COVID, which uses recency, frequency and a hierarchy of sources to resolve those conflicts between the multiple data sets. And the aim is for everyone in the organisation to follow the same method, so you don't have that discrepancy between teams, in one team prioritising recency, one team prioritising frequency, and then a difference in sources used. So it would be really helpful if you could have guidance on that in your reporting. I can share with you what we've developed so far in terms of the composite table, but we're very much trying to be consistent with NHS England and DH, and of course prioritising getting the primary care data and the PDS pilot data when that does come out.
Yeah, that's fantastic. Yeah, we'll make sure that that's referenced, and it'd be great to capture some of the learning that you've gone through for that process.
Absolutely, yeah. Thanks, Meg. It feels like we need maybe a catch up with one or two of these people afterwards, Mike. So we'll make sure that we get those sorted. Thank you, Meg. So next on my list right here is Nicholas. Do you have a question?
Thanks,
Mike?
Rachel. Yes, great presentation, Mike. It's interesting to see that the results you come up as reflected with the information that I've seen my end as well. I work for Midlands Analyst, but I'm embedded with Hereford and Worcester ICB. So what we've done at Hereford and Worcester is not myself, by the way, but we've created here a patient feature matrix, which for all of our patients, we have got a whole host of information, one of them being ethnicity. And to where we've got that from is the spine. We've used that as the reference point, which is fed by all of the providers, as you will know, the GP practice. So we pulled that information down as a single point of reference, as a single version of the truth. For instance, we use that, but there are gaps. Admittedly, there are gaps. But so the other point that I was going to make was Mark Farr has talked about in the past that because he's a chief analyst. I'm sure everyone's well aware of Mark. He's got a very high profile within the analytic community, but where he works, which is down south somewhere. I know he's been involved in a project which was able to classify ethnicity using the name of the patient. I think the provider did it, but is that something? He did it to a very granular scale as well. So he was able to identify different areas of Poland, for instance, or different areas of Czech. So it was very, very good. Or basically go down to this patient's Polish, this patient's Czechoslovakian, to go into a very, very granular scale. So, I mean, would it be a possibility to roll out that at scale? To roll out that process at scale and run it once a year and just have that as a standard? Is that something that could be done?
I have seen versions of that before. So there are, I can't remember which organisation. This is so long ago that my brain doesn't work in that time. But there was an organisation that created these sort of master lists of surnames and surnames and first names and how they link back to ethnic group and other things. So certainly something we can explore within this. We'll need to look at the limitations of that before we recommend anything, but it's certainly something that we can explore, and we can contact Mark to talk about his experience and ensure that that's built in. So yeah, it's certainly something we can look at.
Yeah, I was aware of that, Nicola. So I talked to Mark about it because he was so enthusiastic about it, and I think we were talking about something different. But I think we were talking about things which might have gone into hacker. Mike. So it might have been a presentation, but yeah, we'll catch up with Mark. Thank you, Nicholas. That's really helpful.
Pleasure. Thank you.
So we got Siva. Siva, you have a question for Mike?
Yes. Can you hear me all right?
Yeah.
Hi, I'm Siva Chandrasekharan, working as a population health management analyst in Bexley Council. Basically, from my experience working with different data sets, I think GP data, they're over 90%. Most places they are like complete ethnicity. But the problem they've got is most of the GP ethnicity are read coded. And you have literally about 400, 500 different ethnic groupings there. So first cleaning up that and grouping that into like 16+1 census category is a good way moving forward and linking with that. And secondly, two places, one's the GP practice, the second one is the A&E. Two places, if we have like a marketing push to record ethnicity, especially the 16+1 census categories that are available to be there. That's the first thing that I think that can be easily done through like general marketing push. Second thing, across the country, you have this population health management. So they're integrating data sets across the region. Like in Southeast London, they have BA unit. Similarly, there is a North London one, Northeast London one, and so on and so forth across the country. So that could be a good place where we can improve the ethnicity recording. I thought I'd mention these two things.
Yeah, no, that's really helpful, Siva. So in terms of the first one, it's really useful to think about whether we could use GP practice. And in some ways, I don't know. I can see the value in aggregating up to the census categories, but I can also see the value in actually looking at the granularity within that, because that would identify much better in terms of pockets of inequality and things like that. So yeah, so we'll try and identify examples where people have used GP practice, and again, we will look at how people are using it within PHM, how they're if they're indexing individuals, how they're identifying that person's ethnicity, so that person stays the same throughout everything, because I think that's where these things fall down. But yeah, they're
I
really
think
helpful comments.
Both categories is important, the aggregation as well as but I think the 16+ census category is a good compromise when we start off understanding health inequalities.
Yeah.
So that's my point. Thank you.
That's great. Thank you, Sue. That's really helpful. Thank you. We've got time for just one more, and there is just one more. So that's Mary. Do you have a question for Mike?
Yes, this is going to be quite quickly. I'm a bit worried of us saying that the GP data is like the gold standard, or is going to be like the gold standard. And this is because compared to secondary data, I'm not sure if this has been mentioned before, they only record the ethnicity once. That is when you go to register with a GP. And so for comparability and how it's changing, I'm not sure how that would fit in as the gold standard. So that might be something worth considering, because we know ethnicity is changing, especially for that unknown category. And so I'm not sure if the GP, usually they will update with the ONS census uses that changes. I'm not sure they do that, but yeah, so I'd be a bit wary of using the GP data as the gold standard, because we cannot see how that is changing over time.
That's a good point.
So that's certainly not our intention to use anything as the gold standard. What it is, the intention of the guide is to highlight areas where maybe using GP practice data is helpful, identifying analytics that have used different data sets and different types of things, and providing practical support for people to use that. Now, we may recommend certain things back into NHS England that come through this, that might be about how they improve data within the spine or how they update that. But we're not looking to necessarily promote one data set above another, as opposed to how do you deal with the data sets that are available. So yeah.
That's great. That's great. Thanks very much, Mary. So we're just at time, Mike. So I'm just going to finish off by sharing my screen again for just to show us what's going to happen in the next couple of huddles, because people need to know, and I like to be reminded what to look forward to. So while that's on the screen, I'll just say thanks for sharing that with us, Mike. It's really important work. A lot of work's been done already on the improvement plan. There's been a lot of really good suggestions, and there's so much in Slido as well that we're going to unpick later. You've got a lot of work to do. You didn't realise that, did you, Mike? You came here for a bit of help, but you've got it. Actually, you've got it. And those suggestions that people have made for which can include, I'm sure, case studies, which can be in the guide, which is essentially for analysts to make better use and consistent use and understand the ethnicity data as well. So we've got and thank you, Abby, for contributing. We had a thank you in the chat. So just a quick move on to this is what's happening in the next few huddles. Really looking forward to the next huddle, which is from the Children's Hospital Alliance. I've not had them here before, so that's really great. And there's a wealth of information and a huge eye opener. So please do come to that one. And then the one after that is about a domestic abuse strategy in the Isle of Wight. And we turn to our very own Lucy Morgan and Ewan Hon from the strategy unit, who are going to be talking to us about the open source renal model that they've built to understand future demand. So that, again, huge contrast over the next three, but all of them very interesting. And thank you everybody for coming today. And thank you, Mike, again. And I'll see you all in exactly 2 weeks and less an hour. Okay, thank you. Bye-bye, everyone.
Thanks.